Hi everyone, I'm Taylor England and my presentation is going to discuss the effects of a 5,000 IU a day vitamin D3 supplement on muscle strength in Swedish female collegiate soccer players. So some background, there's an average 1 million people nationwide currently suffering from vitamin D deficiencies. Vitamin D is crucial to body development as it's responsible for calcium and phosphate absorption. And I think we all know that calcium and phosphate are needed within the body for bone mineralization, muscle development, and cellular function. There's two forms of vitamin D. 1,25-dihydroxyvitamin D is the active form, but 25-hydroxyvitamin D or serum 25-OHD levels are the most reliable form of vitamin D to measure. Vitamin D's main source is through ultraviolet radiation, where it is produced in the skin in the form of 7-dehydrocholesterol. However, it is extremely difficult for people to meet their daily recommended needs through sun exposure, which is why vitamin D is also consumed through diet. So vitamin D2 can be consumed through plant-based products and vitamin D3 through animal-based products. But even through diet, people are still failing to meet their daily recommended needs for vitamin D. So with increasing awareness regarding the importance of vitamin D to different developmental factors and with the increasing deficiencies among the population, further information is warranted. So although research continues to vary in regards to serum 25-OHD levels, typically vitamin D will be broken down into deficient, insufficient, and optimal levels. Someone will present as deficient if their levels are less than 25 nanomoles per liter. Insufficient levels are classified between 25 and 50 nanomoles per liter, and optimal or adequate vitamin D levels are typically classified as greater than 75 nanomoles per liter. The recommended daily allowances for vitamin D encourage 600 international units for males and females between the ages of 13 and 70, and 800 international units for both males and females greater than 70 years of age. Several risk factors contribute to vitamin D deficiencies other than not taking in adequate levels through sun exposure and diet. It's been estimated by the Centers for Disease Control and Prevention that since 1994, optimal vitamin D levels have decreased from 60 to 30% among the Caucasian population and 10 to 5% among the African American population. So one major factor contributing to deficiencies relies on geographic location. Depending on where someone may live and time of day, sunscreen usage may be more desirable or additional clothing may be needed due to colder climates. Other additional factors include malabsorption from gastrointestinal conditions such as short bowel syndrome or inflammatory bowel disease, liver disease, aging, and obesity. Vitamin D deficiencies are usually asymptomatic, but physical symptoms typically include depression, fatigue, body weakness, joint discomfort, or weight gain. And results of a deficiency may include osteomalacia among adults, rickets in children, autoimmune disease, or even cardiovascular complications. And although rare toxicity can occur, which is excess vitamin D consumption, typically more than 50,000 IU a day, which is equivalent to more than 150 nanomoles per liter. And symptoms of toxicity typically include nausea, vomiting, weakness, or even impaired consciousness. So getting into the literature review, a fairly recent topic of interest that has been further studied is the effects that vitamin D3 supplementation has on muscle strength. Most studies to date have focused primarily on the elderly population, but have produced promising results. For instance, one study incorporated adults 65 years of age and greater, and they found that decreased vitamin D levels increased their risk for fall, poor stability, and decreased reaction time. However, the study did provide an 800 international unit per day and was of vitamin D3 supplementation and was able to successfully increase their strength and walking distance while reducing their overall discomfort. So with this being said, a population you would probably believe to be researched more in regards to this topic that has actually gained very little attention is the athletic population. The athletic population exerts higher amounts of energy due to increased speed and strength, making them more susceptible to vitamin D deficiency. So this population requires speed, strength, and muscle and bone relief, which is why determining methods for maintaining optimum vitamin D levels is very crucial. So female athletes are particularly at risk for vitamin D deficiencies. During late adolescence, between the ages of 18 and 21, female athletes require additional nutrient intakes due to increasing development of muscle mass and other physical characteristics. However, this population is typically more self-conscious regarding their figures due to social status, which unfortunately a lot of the time leads to disordered eating, which can be seen as skipping meals, bulimia, fasting, or using laxatives. And this typically results in severe deficiencies because these female athletes are malnourishing their bodies of very necessary nutrients needed for functioning. The female athlete triad is actually a term used to define female athletes who suffer from weight loss, irregular menstruation, and low bone mass due to disordered eating, all of which affect their athletic performance. And this is because inadequate energy intake causes muscles to act as the main form of energy due to excess fat loss, which will eventually lead to muscle depletion, and reduced estrogen levels increase the risk for stress fractures. And reduced calcium intake will result in decreased bone and muscle functioning, and all of this shows the importance of maintaining optimum vitamin D levels among this population. So an average 80% of athletes are currently suffering from vitamin D deficiencies, which has been correlated to winter seasons, as opposed to only 48% who are deficient who train outdoors. 90% of vitamin D is provided through sun exposure, which can present as a major challenge for athletes who train indoors during the long winter seasons, and this has been seen especially in northern European countries. For instance, one study found that 131 Finnish female athletes 9 to 15 years of age had serum levels less than 50 nanomoles per liter. However, one 8-week study, which is actually the study that I based my methods off of, performed in the United Kingdom, found that 1 RM bench press, back squat, 10 and 30 meter sprints, and agility tests depicted increased muscle strength among 10 elite soccer players after being provided with a 5,000 IU a day of vitamin D3 supplementation. These tests took place during the winter months from November through January, and the study found that at least 60% of the intervention group had increased their serum levels to greater than 100 by the end of the 8 weeks. So it's very evident that athletes are deficient during the winter months. Indoors or outdoors, different factors contribute to these deficiencies, which is why it's very important to assess supplementation during these specific months. So this brings me to my research question and my hypothesis. Does a 5,000 IU a day of vitamin D3 supplementation improve muscle strength in Swedish female collegiate soccer players during the winter training season? My null hypothesis is that a 5,000 IU a day vitamin D3 supplement will not improve muscle strength among this population. And my alternate hypothesis is that a 5,000 IU a day vitamin D3 supplement will improve muscle strength among this population. So some study objectives are to determine if vitamin D3 supplementation provides benefits to muscle strength in female collegiate athletes, to determine if vitamin D3 supplementation can generalize to the athletic population as a whole as an ergogenic aid in muscular strength, and to determine proper dosages that provide optimal benefits for deficient athletes. So methods and procedures. The study will be a randomized controlled trial, randomly assigning participants to either an experimental group or control group based on a computer-based system. The study duration will be 12 weeks during the winter months of January through April. The experimental group will receive a vitamin D3 supplement, 5,000 IU a day, and the control group will receive a cellulose placebo pill in identical capsules as the vitamin D supplement in order to prevent any bias. And muscle strength and blood measurements will be assessed 2 days prior to supplementation during week 6 and during week 12. So resting arterial blood samples will be acquired and placed in serum separation tubes. For the purpose of the current study, serum 25-OHD levels will be defined as less than 30 nanomoles per liter as deficient, between 30 and 50 as inadequate, and greater than 50 nanomoles per liter as adequate or optimal. Muscle performance tests will consist of strength and agility tests. 1 RM bench press and back squat will measure strength of both upper and lower extremities. Participants will perform 1 complete rep with maximum weight they can sustain. A 2-minute rest will be allowed if participants are able to complete the maximum weight rep, and this performance task will last until they are unable to perform maximum weight any longer. The vertical jump, 1 RM leg press, 10 and 30 meter sprints, and the Illinois agility test will assess lower body strength. 3 vertical jumps will be completed utilizing an electronic jump mat, and the best score out of 3 will represent the final score. 3 separate sprints will be performed using electronic timing lights, and the best time out of 3 will represent final score. Players will also be given 1-minute rest between each sprint. Starting on their stomachs, when prompted to go, participants will jump to their feet and run through a set number of cones. They will perform this 3 times as quickly as possible, and it will represent the Illinois agility test. These strength and agility tests are also typical training methods in soccer, so all participants will have prior experience. Daily food diaries will also be required, where participants record daily food and drink intake, what time this occurred, and what time of day they took their supplement or placebo pill. Both groups will attend weekly nutrition education classes taught by the registered dietitian on the case. These classes will discuss portion sizing and healthy eating, and skipping more than one weekly session will result in the members' conclusion of the study. So 4 women's soccer university teams will be incorporated in the study, all residing in northern Sweden. So Lund University, Uppsala University, Stockholm University, and Umeå University will be the universities incorporated. Body mass index and height will be assessed prior to the study, and other inclusion criteria will include serum levels less than 30 nanomoles per liter. They do not smoke. They have not undergone surgery or any injuries. They do not suffer from an illness. They refrain from vitamin D supplements, fish oils, or any other multivitamins. They are not sunbed users, and they have not traveled to warmer climates in 3 months prior to the study. So a G-Power calculator was used to determine the sample size. A t-test and a priori of 2 dependent means was used with a 95% power, 0.5 effect size, and 0.05 error of probability to determine 210 total participants. 105 will be in each group. The research setting will also take place at Lund University's Athletic Recreation Center and data analysis in the university's research center, because Lund University has actually been ranked as one of the top universities in Sweden for research. So human subjects are involved, which requires approval from the Institutional Review Board. Abiding by the Belmont Report ensures respect for persons, beneficence, and justice. A consent form will be provided at the completion of the fall soccer season, moving into the winter season, giving ample time for applicants. Applicants will schedule a meeting with their coach, the athletic trainer, and registered dietitian. The initial meeting will discuss the study and informed consent, and a follow-up meeting 1 week later will require applicants to sign the informed consent if they're interested in participating. Informed consent will discuss the purpose of the study, why applicants are valuable subjects, confidentiality, and the opportunity to withdraw at any point without penalty. Some risks include physical injuries during strength performances, because deficient athletes are more prone to injury from muscle depletion and vitamin D deficiencies. Due to maybe a stressful day, applicants may accidentally skip or miss a supplement, which could affect final results. But some benefits: the daily food log allows participants to keep track of their daily food intake and discover if they're consuming too much or too little. The weekly nutrition classes teach about healthy eating, portion sizing, which allows participants to make healthy choices when grocery shopping or preparing food. A 1-year free supplementation will actually be provided as an incentive, which will allow participants to decide if ongoing supplementation assists in performance and overall well-being. And keeping a close relationship with the registered dietitian will allow for monitoring overall health and making sure participants aren't overworking themselves. So data analysis will be quantitative and descriptive, since performance measures, dietary intake, and blood measurements will be assessed. The SPSS, the latest version of the SPSS, will evaluate data for the entire study. BMI will be assessed as body weight in kilograms divided by height in meters squared. A 4-way ANOVA with repeated measures will assess isokinetic strength. The between subject factors will include experimental and control groups, and the within subject factors will include muscle, speed, and time. A 2-way ANOVA with repeated measures will assess 25 OHD levels. Between subject factors will include supplementation, and within subject factors will include pre and post intervention. A regression towards the mean will determine if 25 OHD levels change throughout the study among participants. The dietary intake will be analyzed through the latest version of the 10.2.6 food processor software, and dietary intake will also be based on traditional DRI standards for late adolescent females. So previous studies have indicated for limitations, small sample sizes in single gender studies. A limitation for this current study could be that it only incorporates females and from one sport, rather than different female athletic teams. Future studies should continue incorporating both male and female participants and include a wide variety of sports teams. So for future opportunities, it is clear that college-age individuals are at increased risk for vitamin D deficiency. The anticipated outcomes expect that female athletes can avoid deficiency by incorporating a daily vitamin D supplement. The results of the current study will provide further insight into the effects of vitamin D supplementation on muscle strength among the entire athletic population, and it will provide more concrete evidence on guidelines for registered dietitians and sports physicians working along athletes. Here's my reference, and I hope you guys enjoyed. Thank you.